Alright, this is the genitourinary system. So I am talking about the reproductive system of the female and the male, as well as the urinary system with the GU system. So remember, in the anatomy of the female, we have the mons pubis, which is the mound, basically. You have the clitoris, which is at the very top, and it is basically the woman's sexual organ. You have the orifice of the urethra, which is what the catheter goes through. The vaginal orifice, which is the opening to the vagina. And we have our perineum, which is in between the vagina and the anus, and then the anus. Then for the man, we have the external, which is the penile shaft, and then at the top it's called the glans. We have our inguinal ligament, the inguinal ring, the cremaster muscle, which is in the scrotum. You have the scrotal septum, the scrotal cavity. You have the rugae here. You have a lot of nerves and arteries in the inguinal area. And these make up the spermatic cord. So the man's sexual organs are on the outside, which is what the testes are, and the woman's sexual organs are actually on the inside, which is what the ovaries are. So this is just an internal view, basically, of the reproductive system. So with the woman, we have the cervix, which is where the fetus develops. We have the vagina, which is the opening into the cervix. You have the cervical os, which is right here. You can't really see a picture of it. I hope you guys can see the mouse when I'm on the recorded version. Then you have your fallopian tube. So if you remember, your ovary is what houses your eggs. The egg releases once a month into your fallopian tube, and then it becomes fertilized by the sperm, and then it travels into the uterus, where it is to implant into the endothelial lining and makes the placenta, and then you have your developing embryo, which turns into a fetus. That's in the normal reproductive cycle. In your male, you have the prostate gland, which can get enlarged later in life. You have your seminal vesicles, you have your testes, which basically house your sperm, and you have your vas deferens. Okay, in the urinary part of the GU, both male and female have kidneys. The kidneys, if you remember, is where you excrete your waste and retain needed products. So you excrete your waste, and that goes down the ureter, which travels into the bladder, and then travels into the outside world. Next, we have the functions of the female GU system. So with the female GU system, we engineer and shield the ova for fertilization. It moves fertilized ovum for implantation and embryonic fetal development. The GU system houses and nourishes the developing fetus, as well as regulating hormonal production and secretion of multiple sex hormones, and provides excretion of urine. In the male, it also engineers and shields sperm for fertilization. It moves sperm, it regulates hormonal production and discharge of male sex hormones, which with the male you have androgen and testosterone. They have estrogen, but it's not as much, just like the woman has some testosterone, but it's not as much. The male sex organ, it provides sexual pleasure, and it excretes urine. So our interaction with other systems. In the female, the cardiovascular system, it is in charge of nutrients and sex hormones transported to the reproductive system. So your cardiovascular transports these hormones and nutrients. You have vasodilation, which occurs in the clitoris due to arterioles. and estrogen, which lowers your blood pressure, and it has a positive effect on the cardiovascular until menopause. So women have a protective effect of estrogen, and then once menopause occurs, your myocardial infarction risk is the same as a man's. In the male system, again, nutrients and sex hormones are transported to your reproductive organs via the cardiovascular, and then they have vasodilation in the penis, which will help with erection. With the female urinary, you have everything is in close proximity, which increases the risk of UTI. That's why teaching, educating is so important about wiping front to back. Anytime they have sexual intercourse, they should always urinate afterwards. Any type of activity that would cause the vagina to excrete anything, they would need to make sure that they clean it and urinate, because urination will help get the bacteria that could be sitting there out so that the woman does not develop a UTI, because the woman's urethra is much shorter than the male's urethra. Bladder continence is due to the detrusor muscle and the internal and external sphincter and control of that. In the male, the urinary system helps to ejaculate via the urethra. So the sperm travel down the vas deferens and down the urethra for ejaculation into the, whatever orifice they're ejaculating into. The man's prostate gland will become larger as they get older, and this causes compression of the urethra, and it increases the risk of UTI and urinary retention. Men should not have a lot of UTIs because their urethra is so much longer, but as the prostate gland gets larger, it does increase that risk. And then they also have bladder continence due to internal and external sphincter control and the detrusor muscle. For the musculoskeletal system, the pelvic floor helps pelvic muscles to maintain support and protection, and that's for both male and female. In the female, we have estrogen, which helps to maintain our bone mass until menopause, and in the male, they have androgen, which increases bone density. So with neurologic, in the female, it helps to regulate the sexual response. So that's why intercourse is much more brain-related for the female than it is for the male. Their hypothalamus and anterior pituitary will cause a release of hormones, or it stimulates the hormones to be released, which will assist with the ovarian cycle. And then micturition, which is urination, is stimulated by the parasympathetic. In the male, they also have micturition that's stimulated by the parasympathetic. The parasympathetic will help regulate the sexual response, including vasodilation. And then certain areas of the brain will help stimulate hormone secretion. And then in endocrine, the release of hormones cause an increase in sex hormone production. So for a woman, that is estrogen and estradiol, and for a man, testosterone. So some developmental considerations that you should think about for the female infant: their genitals are going to be enlarged at birth because of maternal estrogen. They could have pseudo-menstruation also due to maternal estrogen. Their labia majora should cover the labia minora. Their urinary orifice and meatus should be visible, and they might have masculine characteristics due to progesterone and androgen overstimulation, and that should be looked into. For the male, there needs to be an assessment for hypospadias and epispadias. Hypospadias is the urethral medius being ventral on the glands instead of totally at the top, basically. And then epispadias is when the opening is on the dorsal part of the glands. Their testes should descend by age 1, so if they haven't descended by age 1, they need to be taken to a urologist. Scrotal edema and ecchymosis can be common in infants that were breech. And then the risk of hydrocephalus, which is a fluid, feel like it's fluid around the testes, and an increased risk of hernias can happen until age 2. In children, female children, you want to assess certain areas such as pain with urination, frequent urination, trauma. You want to ask about toilet training, if there's any problems in bedwetting that will help you with developmental issues, and then are they having any urination issues. The pain with urination and urination issues and trauma, those can be UTI. They also could be sexual assault. So you have to figure out which and go down that path. For the male child, they can have redness, swelling, discharge, or foul-smelling odor in the testicular area, which is a sign of infection. It could be asymmetrical. They could have lumps or masses. They could be movable, hard or soft, painful, which can be indicative of hernia or lymphadenopathy. They could be, like you want to ask if they cry and hold their genitals, which could be a sign of strangulated hernia, but it could also be a sign of sexual abuse. It's important to remember that male children can have sexual abuse just like female children can. Has the child ever had a hydrocele or hernia? Any trauma to the area? And again, you want to do toilet training. Any problems with toilet training, bedwetting for developmental reasons, and if they're having any type of urination problems, or if the stream isn't straight, because that could be a sign of hypo or epispadias. Some more developmental considerations. So remember, the female begins puberty earlier than the boy. So in the girl, you might notice female pubescent changes as early as 8. Their puberty happens between 8 and 13, and in boys it's between 9 and 14. Estrogen is released when they go through puberty, and this causes breast buds and pubic hair, and eventually will cause menstruation. The early development will allow the child to become pregnant before they are intellectually ready, so it's very important to identify their understanding of sexuality and sexual practices, and it needs to be clarified and educated. And so very important to educate parents on the importance of discussing intercourse with their children. My daughter is 10 and she knows all about it because she has her period, and I don't want her to get pregnant, so she knows all about it. Safe sex education is needed in this age group, and it's important to assess for sexual molestation, and signs of it: bruising, swelling, inflammation, genital trauma, eating disorders, and depression. Those can all be signs. It's important in the males to also assess for sexual molestation, because boys can be sexually assaulted just like girls can, and they need safe sex education, and boys' parents need to be educated on the importance of discussing intercourse with their children, because boys can get girls pregnant at any age, really. Once they are able, not any age, but once they're able to go through puberty and they start having spermatogenesis, they can get a girl pregnant. And then you want to also identify and understand the male adolescent's understanding of sexuality and sexual practices. So some developmental considerations for the pregnant woman. They go through significant changes when they're pregnant due to the fluctuation in hormones. The woman's uterus will enlarge 500 to 1,000 times the non-pregnant state. Amazing. The vascularity of the cervix increases and it softens. It also has vascular congestion, which is called Chadwick's sign. Basically, the cervical os and the cervix will get like a blue purplish color. And then the vaginal walls will soften and relax, and that helps with the birth of the fetus. So in the older adult, estrogen declines in the female. She will go through menopause generally between 46 and 55. That is considered to have occurred once you do not have a period for 12 months. The female sexual organs will begin to atrophy. They have a smaller clitoris, less vaginal secretion, so their intercourse is more painful, and these changes can increase the risk of vaginal infections. In the male, they also will have atrophy of sexual organs. Their testicles will become smaller and softer. Their prostate will become enlarged. And again, that can cause urinary issues. The elasticity of the scrotal sac will decrease, so it will start getting larger. The testosterone level decreases by age 50. The male will be able to produce sperm throughout his entire life, but the productivity of that sperm decreases as he gets older. The male has the same physiological response to intercourse. However, the time required to achieve erection will increase, and ejaculation is less intense. The male will have decreased seminal fluid, and then their time to become flaccid will decrease. Impotence in the male older adult is not a normal part of aging. So if a man complains of impotence, it's probably because there is something else to blame, such as cardiovascular issues or diabetes. Trying to get that through to a younger male is very hard, though, to make them understand that later in life, if they do certain things, they will be paying the repercussions of those things. Some cultural variations. There's varying practices for a pregnant woman in different cultures. So like the Chinese view it as a hot state, I believe. Certain cultures, they don't want a man to perform a female exam. So like Muslim cultures, they only want a female to perform the female exam. Circumcision for the male is considered religious for Jews and Muslims. However, the American Academy of Pediatrics does not advocate for circumcision, and they say it's the parent's decision. If a parent does decide to not circumcise, they need to be aware of penile hygiene and the importance of retracting the skin and cleaning the glands of the penis. So with the health history of the GU system, you definitely want to have a rapport, because this can be a very uncomfortable situation for both patient and nurse. So the nurse needs to make sure that they are professional throughout this assessment. So certain questions that you would ask your female patient. So you want to know if they're premenopausal, when was their last period, if they're having any pain in their lower abdomen, any vaginal pain. Like there's a lot going on there with the internal organs and somewhat with the external. So you want to make sure that you assess where, do your old cart, onset, location, duration, characteristics, aggravating and relieving factors, and any treatments that they may have done. Describe your menstrual cycle. When did menarche begin? You want to ask if they are menopausal, when did they become menopausal, and if they're having any abnormal bleeding. Especially in the older adult, abnormal vaginal bleeding is very indicative of some kind of uterine cancer. What is the patient's sexual practice? How many partners do they have? What is their sexual activity? What is their preference? If they're bisexual or homosexual or heterosexual. Are they practicing safe sex? If they're not, educate. If so, what do they use? What type of contraception are they using? If they say they don't want to get pregnant, but then they say they're not using any type of contraception, that's something that needs to be educated on. If the woman has an OB history, we need to know, like, when they last were pregnant, how many pregnancies have they had, have they had any spontaneous or elective abortions, have they had any live births, any premature births, how old were they when they had their first birth. We'll want to know if they have any vaginal discharge, and then to describe the vaginal discharge. Have they noticed any certain lesions or discolorations on their vagina? Have they had any specific genitourinary surgeries, such as tubal ligation or hysterectomy? Any type of STD, sexually transmitted diseases, sexually transmitted infections is I think what it's called now. If there's any type of uterine, vulvar cancer. Are they on any medications, any oral contraceptives, any hormone replacement therapy? And sometimes people forget that the Mirena is a medicine. So you need to specifically ask also if they have any intrauterine devices. The copper T is not a medicine, so they might not tell you. Implanon is a medicine, but they might not tell you because they don't think of it as a medicine. And any specific urinary issues, such as any burning on urination, any dysuria. Oops. Oh, did I not put this in here? Oh my God. Did I do it backwards? I did do it backwards. I didn't mean to do that. All right, so the focused history for the male, are they having any penile pain, any lesions? What are their sexual practices? If they have a certain amount of partners, if they have multiple partners, what are their preferences to, in regards to intercourse? Are they practicing safe sex? Are they using protection? And again, educate if they're not. Are they having any discharges? And if so, describe the discharge. Don't hit my pencils. So if they're having any discharge, any penile discharge, they need to describe it so you can follow up on it. History of GU surgery. So if they've had like a TURP, a transurethral retroactive prostatectomy, or a vasectomy, any medicines, any related medical problems, specifically for men, because diabetes can affect a woman's GP too. Cardiovascular can too, but it's more predominant with men because their sex organ is external. And then any urinary problems, also like such as dysuria, frequency, all those good things. And then, since I went backwards, I had this on the wrong way, we also need to do the assessment. So the assessment is going to be the internal exam is going to be performed by the MD, such as the speculum exam for a woman or the rectal exam for the male or female. You want to also ensure that they have modesty, because this is a very sensitive area, and it can be embarrassing for patients, and they don't want to talk about it, and they don't want to show it to you. So make sure that the patient has that you're maintaining their modesty, you're draping them, you're ensuring their privacy. Want to make sure that you are accompanied by another person. If another RN can't accompany you, then you need to have an assistant present when you're performing your inspection and palpation. It's best to, if it's a specific complaint, it's best to have you and the doctor just do it at the same time, so that the patient only has to go through this once, because of the fact that it is a very sensitive topic. So if you can't be accompanied by the doctor and you're accompanied by another person, you're going to inspect and palpate. Make sure if it's a younger person that the parent is there, because you might they need to be present if you're doing anything like this on their child. But you're going to inspect your external genitalia for anything abnormal, such as lesions, and then for like the scrotal one, the scrotal exam, you're going to also palpate the scrotum. You're going to make sure there's no pain with palpation. You're going to palpate the inguinal areas of both the male and the female. And that's pretty much it. And then here are, oh goodness, here are my references should you want to look any further into this. All right. Thank you very much.